This morning we introduced the concept of CAS and how we think it's relevant for studying health policy process and health systems. This afternoon we are going to introduce uh, the health policy process in China using the CAS perspective to study, because this is something lots of people are interested in knowing health system development because China has really achieved the historical progress in universal coverage. By the end of last year, we have 1.3 billion people covered by various programs of health insurance. So how can we really look at this one? This is one of the cases we are going to introduce in the later sessions. This is the class we will talk about focusing on health system, and CAS, and why health system is considered as a CAS and the process in China. What I like to do is I'm going to I will record this one. What I think this morning the flow is you introduce what is a system, right? It's really a unified whole. And then from a system, you instead of thinking apart, you think a whole. And then from the system, you look at we say linear, nonlinear, and move to a system is a complex and adaptive. From a static approach, really to a dynamic approach, because the agents they are interacting, evolving, and changing. So this is the system, so many elements in there. And in this process, you can see emergence, you can see lots of nonlinear nature of the system and the decentralization. We'll talk about the characteristics or features of the system. Now we want to move toward you consider healthcare, because this is a system we want to apply CAS into the health system. We move to the health system by thinking through using the metaphor. We introduce the metaphor as a way of thinking, a mental model. And then we can see whether now this CAS offers a different perspective in looking at the health system. So this is the general approach. However, this class is for developing countries, using China as a case. For developing countries, we know it's so difficult to develop human systems. Why is so difficult? We know we build so many railroads, we build so many buildings, fancy buildings. But how we thought we could solve the healthcare system problem, healthcare reform. We face so many challenges. It's such a thing for us as human development goals. We always look at the health, education, social protection. So how those processes evolve from the complex adaptive system perspective. This is one thing. The other thing we want to look at specific health policies. One is introduce how those policies will generate anticipated and unanticipated result. Because reform means you introduce different policies. And also how this way I'm going to introduce, add one more section is the methodology. Lots of people take, quantitative skills, state the modeling, linear or nonlinear, limited dependent variables. Lots of people take qualitative, different qualitative. I know there are many different types of qualitative methodology. How CAS will have implications for you to look at the methodologies. What kind of methodology should be used in studying CAS? So this is the general flow. This afternoon we look at using the health system as a case. What is health? It was defined by WHO as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition is really gives a static image of what we view as a complex system. It's not a very dynamic. We know the challenging for studying cases, we know it's no single discipline for systematic thinking as CAS because they're rooted in many disciplines we discussed. CAS approach is a paradigm or perspective that considers connections among different components. This is more we introduced. Plans for the implementation of their interactions, and it requires transdisciplinary thinking as well as active engagement of those who has a stake in the outcome to govern the course of change. I want to focus on the transdisciplinary thinking. In addition, you have to think about actively engage of those people who have a stake in the outcomes. It's not automatic. We know the outcomes of people engage the agent. They can have different way of changing the governance structure. I want to introduce the course of change. Who governs the course of change? Is the government? Is the expert? Is the doctors? Or general public? So that's the system approach and looking for the development. It's not I'm just a passive agent in the system. The system, the agent can be very active. They can actively engage in changing the directions. So this is something I want to add it, and later put some emphasis on that. The critical thinking part is we know the heart of a system orientation is an emphasis on relationships. We know in human system, understanding the nature of a system and its dynamic requires an understanding of people, such as how we interact with each other in social networks. That means we are human beings. Every agent, they have their own value, their power, their relationships. They are not so. When we study health system, human system, those agents are people. It's different from those biological system. We talk about that. Is sufficient understanding of the parts are essential to a reasonable assembly of the whole. In the morning, we showed the yin yang diagram. But if you don't know the operation of the parts, how can you really understand the operation of the whole? So oftentimes when you study CAS, you have to have knowledge on the parts. And then when you put them together, assemble the system, you have a better understanding. You have to know the incentives of doctors and incentives of the patient, then you can understand the hospital operation. A system thinker requires us to transcend the academic boundaries. That means it's not just one discipline. You have to, know multi-disciplines. And different discipline has developed different methodologies. Because some disciplines, they use different methodology, like a health economist. They use lots of modeling. The management, they use their own methodology. I think it's also management is multidisciplinary. So it's really require us to use mixed methodologies. So we'll add a section on methodology in the course, because when you're rooted, we often talk about this is disciplinary, interdisciplinary, multidisciplinary, or transdisciplinary. It means quite different things, and they use different methodology and models. This is a transdisciplinary character of health. We just do a simple, single disciplinary, how they define a problem, health problem, versus transdisciplinary. This table is really, we'd say how health problem is defined, what kind of collaborations work, and the role of conceptual framework, and how knowledge is applied. So you will have this in when you download the PPT, you can study. It's a different definition, different way to approach it. Is the transdisciplinary, and we go to a chart. A single discipline, you have a problem. Different disciplines, they have different definitions. And also multidisciplinary means you can have looking at things from different angle, and interdisciplinary is how you really integrate. Give you one example. Look at the poverty. is different defined by economists, sociologists. But if you say multidisciplinaries, they still work together, but they look at the problem still from their own perspective, and then you're trying to reach some agreement. But interdisciplinary will be different. So I think this is the approach, the methodology. I'm going to add a section on how you look at this. This is the ways of knowing from a disciplinary perspective. You know, we have a different relevant. Why anthropology is important because it's a way of looking for the issues, the community, culture, sociology, political science, economics, other epidemiology. Professor Liang Xiaoyun is an epidemiologist. And so we say, gee, why the school has so many people coming from different disciplines: chemistry, biology, medicine, psychology, demography. Because that's the aging population. You need to know our whole. China is every 7 people we have one is over age of 60. By 2013. By the year 2033, we have every 4 people will have 1 people over age of 60. So it's an integrated conceptual framework. You have social ecology. We have some kind of interdisciplinary, but the common conceptual work is transdisciplinary. For example, you can have multi-level analysis, different levels. You have to combine qualitative and quantitative. You have to combine the emic and ethic approach. Emic is really looking things from the cultural perspective, a community, and all the conceptually. It's more culturally centered. But ethic is really scientifically approach, trying to have a cultural neutral perspective. So you really have to combine these two approach. On the one hand, you want to understand the context, but there are some general principles derived from different contexts, and then you develop a transdisciplinary approach. You can Google for emic and ethic. It's a two approach used in understanding what type of knowledge, how you really get different type of knowledge integrated. Health and human health or illness. We know human body is composed of multiple interacting and self-regulating physiological systems. And we know the behavior of any individual is determined partially by an internal set of rules based on past experience and partially by unique adaptive response to new stimuli from the environment. And the web of relationships in which individuals exist contains many varied and powerful determinants of their beliefs, expectations, and behavior. Give one example about health. This is how complicated. You look at smoking and health. This is one of the challenge. I'm working on tobacco control. People have different beliefs. The white collar, well educated, the harm of smoking. But if you go to, many parts of China, they think, gee, when SARS was here in China in 2003, many people thought, gee, smoking helped me to prevent SARS. It's a different belief. Now they think, gee, smoking is comparing with air pollution. It's nothing. It's different context, different belief. It's really complicated. And the behavior, we think, gee, we can have, nutrition. And you look at people's body response. Diabetes is one common disease. We have 96 million people with diabetes in China now. The rate is very high. How can you really think about, when aging is coming, this disease pattern will change, the whole healthcare system, maybe even the national economic system. So it's lots of define and changing. It's very complicated. We don't know which trigger. No, we're trying to see this is the way to control it, that way to control. We have some kind of, that's the ethic approach, common understanding of the health and illness. So a health system. So we talk about health. Coming to the health system, this is the definition by WHO in 2012 is a good health system delivers quality services to all people when and where they need them. The exact configuration of services varies from country to country, but in all cases requires a robust financing mechanism, a well-trained and adequately paid workforce, reliable information on which to base decisions and policies, well-maintained facilities and logistics to deliver quality medicines and technology. Each country has different elements. We did a comparison between China and Brazil. We found the elements are different, but outcomes are so similar. But how each country, you have to have some kind of financing. You need money, workforce. You need people to they have the kind of skill. You need information to make decision where to put the money in, which area, or which technology you want to adopt. You need hospitals, facilities, logistics. So those things are, you combine them to become a country's health system. And you can subsystem that like a health financing system, services system, for different parts. If you set up the boundaries, each component is alone is a system, but they are all forming for a general health system. This is describing the public people. We know the resource. You need the money, resource part. Not only money, human resource, knowledge, technology, capital, pharmaceutical, consumables. You need the financing, you need service delivery, and the storewood. I will talk a little bit. You need providers and the state. And outcomes, we always say the health status and the protection from health impoverishment. That means poverty issue, and the trust and satisfaction. People are happy about they got treated. They are satisfied with the service they received. So the key functions of the system requires the storewood. It requires the resource generation and the financing and the provision. You need to collect the revenue. You need pulling the fund. You need to purchasing services. You have personal service and non-personal services. The financing means raising revenues. Either government put the revenue or you pay your premium. You pay by your pay insurance. Now we have a deduction from your salary. 11% of our salary, will be paid into the system. You need to pull in the resource from individuals and to see what's the best way to do it, allocating and purchasing the services. So this is the financing system. And also we know the financing is part always, each country they have account for a certain percentage of their GDP is increasing, changing with income. And the service provision. You need a prevention. We know prevention is very valuable, but in reality, prevention is, everybody realize prevention is important, but in reality, prevention is always toward the end. They always care more about treatment, rehabilitation, palliative care, and the promotion and prevention. Those are the core issues. We put them here. We know that's the most important things, but in reality, if you look at funding and the allocation of the resource, it's not there. It's on treatment. Resource generation, we know human resource. Human resources, you need doctors, nurses. Now we have an aging population, coming. We need people to care for them, caregivers. Those are all the resources, human resource. You need pharmaceuticals and supplies. You need the medications. You need the medical technologies. Now it's so powerful nowadays. The technology they can, PET scan, all those fancy technologies, and I've never heard of those things while I grow up. Health facilities, building the hospitals. If you go to Beijing, the traffic jam is always, the traffic jam, where that's the hospital there. You need the knowledge, you need to do research. So those are, the research generations. Storewood, store shape. Store shape means the overall system design. It's how you do the performance assessment, how you set up the priorities of policy and resource allocation, and what the intersectoral advocacy. This is very simple. You have to fight with Ministry of Finance for, a portion of GDP allocated to health. You need the regulation, you need consumer protection. Those are the store shape of the system. An effective regulation in the health sector is so important. You need the formal and informal rules of the game, the incentive. Lots of, the rule. This is the part is so challenging. Lots of debates. Lots of debates on that. You assume the doctors. We all know the doctors will save people's life, will generate public goods. So when we know they make millions, income, and the poor people have to, got impoverished. This is kind of an incentive structure. Sometimes you can't ignore it. We know the local institutions beyond government can be effective. Professional organizations, media, consumer schools. And each country, like you go to the U.S., American Medical Association is so powerful. But it's a powerful outside the government. But we have China Medical Association is so powerful within the government. Those are the things, the local institutions. We know the co-production regulation may be more effective. It's how you really get, the regulation drafted by all the stakeholders. They can really put something constraints on the behavior, on the incentives. Those are the regulation in the health sector. We have to pay attention. Store shape tools, we talk about policy tools. Store shape, most of the time refers to policy. You need to make a policy. Policy making is so difficult because so many stakeholders are involved. You need to establish and enforce laws and regulations, like antibiotic usage. We have the laws, we have the rules. Who is going to enforce it? So the law and the enforcement, we know the public disclosure means you have to get people's information. We know we have 16,000 different type of drugs already issued, obtained license. Is the process transparent? We know so many drugs on the insurance reimbursement list. How this process is governed. And professional self-regulation. They have to form different groups. They try. That's not to accept. They signed agreement not to accept hongbao. Right? That's a self-regulation. Can they be enforced? And the consumer advocates. How much the consumers' effort can be involved, and independent media. You need the media to really cover those incidents, and also independent monitors. Do we have it? Each country has different arrangement, different system, the store. So those are the tools. So we just basically introduce health system and how we apply, how CAS is relevant to the system. So we have two questions: is the CAS and health this relationship, and how to understand the concept and the core functions of health system. Now we go to CAS and health system. Why health system is CAS? Is most biological, social, economic, and physical systems that have many interacting agents in a changing environment. That's cats. This is the property we talk about in the morning. Many, we just repeat it again. Many interacting parts. I want to, I want you, when you walk away from this classroom, you will remember what is cats, what the key features, many interacting parts, and the emergent phenomena, adaptation, task dependence, specialization, modularity, dynamic change, competition, cooperation, decentralization, and nonlinear. If I were you, I would remember interacting part, emergence, adaptation, path dependency, and nonlinear. 5. It's very useful. The other 4, they can be, many ways of describing different systems. Why CAS are relevant to health system? This is the part. Intervention that may work on small scale research settings or one country cannot be simply replicated elsewhere on a large scale. It works in my community, but when you're trying to expand it, it won't work. It works in one country. When you say I'm going to transfer, policy transfer to another country, may not work. It's just simply, you can't simply transfer one country's experience, one community. That's the AMIC approach. You think about, gee, I can transfer to another place. Oftentimes, it will fail. Control over behaviors of communities and providers is limited in real world. Now we have so many regulations signed, not receiving hongbao, there's a bribe. And it may not work in the real world. You think, gee, I can control the providers, hospitals, and even simple interventions involve complex social interactions. Sometimes just think about the one thing is essential drugs. I only have several drugs. You can't prescribe it. It may not work. And unintended consequences are very common. And variability in implementation is the norm. That means, if you design a system, when you implement, there are all kinds of stories. Implementation is so important. So health systems, especially in developing countries, are composed of highly heterogeneous groups of actors. Developing countries, we have so many, started from, many types of healthcare providers, managers, policymakers, patients, regulators. I also intervention can happen at multiple levels. So developing countries really not well developed. We have barefoot doctors, we have clinic hospitals, we have private hospitals, public hospitals. So it's many actors, and the interconnectedness of actors and their dynamic interaction across the health system closely resemble the characteristics of CAS. This is talking about, health system is a CAS. We know health organizations also can be seen as complex adaptive systems, not equilibrium seeking. They are continuous, emerging, and changing. There are several characteristics that can lead to us to think about, the health organizations. Health is a case, health system is a case, health organizations are case. So basically, you can see almost everything involved. You can define them as case, and then you can think by these 9 features we described. And there are some examples we can see the phenomenon of CAS. Path dependency, we talk about the 9 features using this is one case. Health reforms such as introduction of social health insurance or quality insurance program may work well in one country but cannot simply copy to a developing country and have similar results. We had a lot of debate in using Canadian model, British model, US model, whatever, starting 2007, we see which model works. So sometimes the past dependency, it's none of the model works because we have employers insurance. That's what's the model, the U.S. model or German model. We have urban residence insurance. That's the model. That's the Canadian model. No, in China itself, we have several different way of financing a health insurance programs. So that's past dependence because we started the reform from the planned economy, from state-owned enterprises. So we start to build our system for from the employees and gradually expanding to rural residents and urban residents. In this process, our development paradigm was called harmonious society. Government had money, and we had a high growth of revenue. Government started to put money in building the system. And we had lots of debate on using the market tools or using the government tools. So that's a past dependence. Adoption of different standards of technology in different countries will be different. For example, e-health and m-health. It's different approach. When you have a system, you might have a different attitude. So it's a past dependency in each country's health system. Feedback. We know the poverty and illness. That's vicious circles. We know malnutrition infection. So lots of things, one aspect, they can create something else. We know the price, the swing in the price of or demand for certain health services. We know, the standard model of healthcare delivery continue to serve the same populations but fail to reach the poor. So it's lots of feedbacks. We think, gee, we can change it, but it won't change that way. And emergent behavior. Sometimes you can see health workers can suddenly organize to go to strike. I can tell you this story. In Hunan, we're trying to get, purchasing the drugs, to the centralized system from the pharmaceutical companies. They began to lower the price, and they were on strike. Sometimes, you think about now we see the relationship between doctors and patients. And it just changed so dramatically. Now we started to hire to train medical social workers. Medical social workers' main role is to mediate relationships. So the emergence of the system is something we never anticipate for medical social workers, health or hospital social workers to perform that role. So this kind of emergence in our system. Phase transition. I want to mention a little bit on the phase transition is the nonlinear nature. Is the tipping points in health services, leading to sudden change in demand for health services or change or referral patterns. The tipping points, when we introduce a policy, they may change the behavior to a certain standard. You could see something really change another phase. I started to do the county hospital reform. That was 3 years ago. We found, okay, gee, county hospitals has more a sudden increase in inpatient care and outpatient care. And then they said, well, gee, we have to build new hospitals. We have so many patients. It turned out is the county clinic, they won't see patient anymore. So they all refer to the county hospitals. And this triggered a whole round of rebuilding, building a bigger and bigger county hospitals. So that tipping point really transformed the rural health system. Now you want to strengthen the township clinics, but you have such a huge, leapfrog of this, leap forward of the county hospitals. They change the whole structure of the facilities in the rural area. The county hospital really becomes central, and now you have to really reform the rural health system based on such a huge increase in the capacity of the county hospitals. So that's a transition point. And also changes in collaboration, competition behaviors, and referral patterns. That's what we're talking about one in central drug policy, they can really have phase transition from one phase. This is the tipping point is you got one policy, they change the whole structure. This is what I call tipping point. It's the transition of the capacity in service delivery and in financing. So how CAS can inform health system reform is we have to have a better understanding of dynamics between the health system, the contextual factors, and population health. You really have to think about is now if we say we put all the resource into the county hospitals, big hospitals, and we are facing the population aging, actually it's faster in the rural area. How can we put prevention in there? We have to identify the root causes of variations in service delivery, and I'm going to give a little bit more details in later. And identify multi-sectoral factors that which promote diffusion of innovation in complex systems. And we have to have better understanding of intended and unintended consequences, and the new tools and approaches to understand and facilitate decision making. This is the one currently very significant. We're talking about using information technology, because in the past 20 years we have really have collected almost all the behavior and digitalized the data. How can we use that one thing to change the behavior or control the behavior of hospitals and the providers. The other thing is getting to know where the waste in the resource, where the scarcity. So how can we really balance? So the new tools and approaches is coming from information technology, and that might provide something I think will be interesting is most of currently when we apply CAS to health system based on case studies, we might be able to use the big data. Once we have the information, we know the context, how people behave on different communities. So I think it's really CAS is a good theoretical alternative to examine health policy and health system development. Especially the agent-based model can help gaining better understanding of the policy implementation process. Because when you introduce policy, how this policy change the behavior of different agents. And this is quite also the way of using it to evaluate policy implementation. That means if the policy has intended goals, we know when you design a policy, you always say, okay, a policy is to solve a certain problem. And the normal way of evaluation is, this is a problem, this is the intervention, we should, to a certain extent, whether or not we meet the policy goals to solve the problem. But once in a complex adaptive systems, when you introduce policy and the agent behave differently, and then you have different emergence, sometimes you can see is the problem solved, or problems are in the process of solutions. I mean, you're trying to solve a problem, you got provide a solution, but you generate lots of new problems. Maybe in the process you find new novel solutions. You never anticipate, gee, something happened. So this is something we use CAS as a way of evaluating the policy. The other thing is the interplays of context, mechanism, and outcomes can serve as a good framework to understand large system transformation. Why this is important? This course is intended to use the CAS to examine health systems in developing countries, especially in China, like a very large system. A large system, we started from the previous planned economy. Each work unit had its own clinic. To a market economy, the whole provision system got transformed, changed, or collapsed. And then to a system, you rebuild it in different, so this transformation is how different agents and how the outside environment. We know the health system is also embedded in China's economic and political and social system. How that system, the context and the environment and the interplays. This is a case we are going to describe later in the class. The other thing is, given the nature of rapid change in the health sector in developing countries, perhaps not only the initial stage of systems matter. Why we talk about initial stage? That's the history. That's the past dependency. That's the memory. The memory part I want to give you now, traditional medicine. We say Chinese traditional medicine. That's a memory of our system. How, I haven't seen any good study of the interplays between traditional medicine and the Western medicine, how that one in this development process. So we call it past dependence. Also, the changing nature of context is important. Why the changing nature of context? In the beginning, it's a GDP driven. Everything is for growth, economic. We largely ignore the poverty issue and health, education, all those things. And then we try to build a harmonious society, and we start to build health system, education system, and social protection system. Now China's economy is a new stage of, it's kind of a slowdown. We call it new normal. And the system itself is gradually mature. We have to do integration, repetitive resource the waste. We have to really reduce inequality, the rural and urban, and different, subsystems. So it's a different stage so this is a co-evolving process between health system change and micro policy and institutional change. Now we have a family planning and health ministry combined, institutional change. So we have a different, by the year 2020, we are going to enter, moderately well-being society. We say 小康 society. We are going to eliminate poverty. How could health system help? So that's sort of the challenges. Is not you put health system embed into a larger system. Not only we have to think about this comes to the approach about the system case is you look at the system from the lower level to see the emerging at upper level. You're trying to bridge it. That means the field knowledge you get to the system. But on the other hand, you have to think about if you can't solve the problem. It's automatic, everybody has incentives. What to do is that you have to change the incentive. How can you change the incentive? Is to really looking a bigger design and from the higher level to change the lower level. So it's really an interaction between the emergence from the lower level and the micro policy intervention or policy environment change, because we know every system has interactions. For example, in the last round of healthcare reform, how can we release the potentials of doctors? They can better serve for the general population. You have to reform their pension plan. We say 事业单位, that's a public service units, lots of rules. You have to give them lots of different type of healthcare system. So this is something you change their own, all the policy that we saw, we say changing the external policy environment of the system, which Professor Liang Xiaoyu and I, we did a report on changing the outside environment to see whether or not we could change, reverse some of the negative incentives. So that sort of case is not only looking for emergence within, also interactions between a system and its environment and embed the system. So system means you have a unified whole separating from others. But the separation is really the boundaries. It's kind of not saying you are away from other systems. It's the interaction part oftentimes offer a better solution. This is the part we will give using the NCMS, the rural healthcare rural health system development, to provide the case. Look at this. The other thing is we know the system, development go through phases, from ice to water to steam. So different phases and the mechanism transitions between phases are now well understood. So how the system transform itself, like when we had SARS, we started to build our CDC system. It's really growing and it's stabilizing. So why and how transition happens? What are the triggering mechanisms? Which factors determine the transition process? and the direction of system transformation are all important. You want the system transformed toward that direction you want. It's not like a free flow of the process. You have to sort of become engineer to try to steer the whole process. This is called top level design in our own language. That means you have to design something system anticipating things might change. We know the other thing is a lot of literature on policy implementations. It's a huge literature. But how can you link the case with a new perspective is the influence of different policy designs and choice on policy implementation. And China has offered quite a lot of stories on how we implement this system. I'm going to give a little bit more on the implementation part. Later, I will have a separate section on implementation. The other thing is managing the transition. So it's the interplay of policy design and decision making, health system adaptation and transformation, and the coping with the external and internal changes. How each system has its goal. The goal means you design a system you want to achieve. For us is we want to have using the investment in healthcare system to achieve the goals of reduce poverty, control the out-of-pocket payment, and enhance access to good quality service. But nowadays we found we put lots of money in there, but are we achieving our goals, stated goals? This is something we say derivation of the goals. That means this is the direction you want to move, but oftentimes you stop in the middle, or you go to another direction. This is the whole process. Oftentimes we change our goals. Give you one example of in implementation changes goals. In the early 1990s, the U.S. implemented community-based healthcare for the people with Alzheimer's disease. The assumption is too expensive to stay in the institution. And I was part of the team to do the evaluation. It turned out all the goals, saving money, didn't achieve. It's most of the goals we saw intentionally say we're going to be more cost effective. The only thing we never designed the goal is the elderly were happier. So that means sometimes this is good. We didn't save money, but we didn't overspend the money. But when people are happier, that's a goal. But that's not design in the system. So sometimes you think about you design a system. How can you really work together, design the incentives to allow the agent interact? You can yield positive outcomes and achieve your goals. So oftentimes, NCMI is we did a paper on looking. It's a meta-analysis looking for all the empirical results showing whether or not we have achieved the goal of poverty reduction of poverty. We found it didn't achieve that goal. But if you look at the rural residents, they are happier. And then that's a political goal because that's kind of support for government policy. So that's sort of I think about how this CAS can be applied. I'm going to provide the summaries. System thinking in health system involves understanding health system actors, functions, principles, and purpose. Making changes in financing, organization, oversight. That's the story. Looking for responses in actors, health services, money, information, everything. You can make better decisions, and monitoring effects on intended and unintended outcomes. So we have some questions for you. Is why do we think health system as complex adaptive system? Maybe perhaps you can give an example in just draw some chart. So that will help. And there are also literatures we uploaded in the Blackboard. We have quite a lot of articles, collection of articles. You can download one article and draw the chart based on that article. Help you to gain understanding of the properties of the case and how they analyze the system. So it's taking 1 or 2 articles, read them carefully, and applying case to draw by yourself. That will be very helpful from my perspective. I'm going to take a break, and we can go through the session of this afternoon.